All right, the clock has struck 12:15, and so we're going to go ahead and get started. Thank you, everyone, for joining us for our first clinical conversations for the new academic year. And if you haven't met me before, I'm Barry Sarvet. I'm the medical director for McPap, and it's really our pleasure to welcome you and to introduce our program for today. As you know, McPap Clinical Conversations is our ongoing program that occurs on the fourth Tuesday of every month. And today's topic is substance use support in primary care pediatrics, a new virtual substance use disorder counseling service through McPap, and our presenter is Dr. Sharon Levy. Just a bit of housekeeping. The session is going to be recorded and it will be available on the McPap website at www.mcpap.org, as is the copy of the slides. And the slides are available under the About McPap tab, particularly on the newsletters and webinars page. We will take questions because this is a clinical conversation, and we hope that you guys have questions so that we can have some back and forth. If you do have a question, please type the question into the question box during the presentation, and we'll either read your question or you can just request that your line be unmuted so that you can ask it yourself. At the end, you're going to receive a very brief survey, and we really value feedback. And so if you could take a moment to fill out the survey, we'd really appreciate that. All right, so again, our presenter for today is Dr. Sharon Levy, and I want to tell you a bit about her. She is a board-certified developmental behavioral pediatrician. She also has a master's degree in public health, and she's an assistant professor of pediatrics at Harvard Medical School. She directs the Adolescent Substance Abuse Program, or otherwise known as ASAP, in the Developmental Medicine Division at Boston Children's. And this is a program that includes clinical research, training, and policy components. She has evaluated and treated thousands of adolescents with substance use disorders and has taught national curricula and published extensively on the outpatient management of substance use disorders in adolescents, including screening and brief advice in primary care, the use of drug testing, and the outpatient management of opioid-dependent adolescents. She is currently the co-PI of a federally funded, actually SAMHSA-funded SBIRT project and an NIAAA-funded study validating the youth alcohol screening tool in a population of youth with chronic medical illness. She also has a Conrad Hilton-funded study that aims to validate adolescent SBIRT measures and test a brief intervention for medically vulnerable youth. Again, please use the question function and feel free to just type in questions as the presentation goes along, and we'll, at the appropriate time, either read your question or unmute your line, according to your preference. So thanks again, and I'm going to just hand over to Dr. Levy.
Thank you. I want to thank McPap for inviting me to speak at this webinar today as part of the Clinical Conversation series. I'm going to talk a little bit about screening and brief intervention, and I think that this is something that this audience is well aware of and doesn't need a lot of time spent on that. I just want to make a couple of quick points about it, and I will also want to use the webinar to introduce a brand new virtual substance use disorders counseling service that ASAP McPap will be offering. And in fact, one of our panelists for this clinical conversation, Maria Alden, has joined the ASAP McPap team, and she'll be providing this service. And you'll hear more about that as we go on in the webinar. So I want to make the case that it's so critically important that we identify substance use and make an intervention in pediatric primary care. I think many in this audience would agree. But there are a couple of reasons that it's so important. We sometimes underappreciate. So first of all, substance use is extremely common in the high school age group, according to national survey data, or our local data. About 4 in 10 high school age students will report past year alcohol use, and 1 in 10 will report consuming at binge levels in the past 3 months. So not only is alcohol use common, but heavy alcohol use is common. 3 in 10 will report past year marijuana use, and 1.5 in 10, or half of those who report using marijuana, will use it heavily, at least monthly or more. Many of these kids are using daily or more than once a day. So use is common, but then heavy use is also common. When you think about the proportion of our patients who have any given medical problem, these rates are really very high. And alcohol use is not just a nuisance, it's not just bad behavior. It's associated with real medical consequences that we all know, blackouts, which actually represent neurologic injury, at least very temporarily, and are associated with unintentional injuries, and over time, problems with memory and learning. And when you think about it, when we have these consequences from lead exposure, even at very low levels, we move mountains, we literally take down buildings and rebuild people's houses to get the lead out of there. And so, we need to be paying that kind of attention to similar level of injury from substance use as well. This is from a paper from data that we collected at Children's Hospital of kids coming in for primary care. These were not coming in for substance use evaluations. These were just kids walking in for routine checkups. And you can see of the kids who reported past year marijuana use, nearly more than 1 in 4 of them reported having an hallucination associated with marijuana. About 1/3 of them said they had experienced paranoia or anxiety. And when we put those together, more than 40% had experienced a psychotic symptom while using marijuana. So again, it's not just a nuisance, there are real consequences, there are medical and developmental and functional consequences to this substance use. So point number 1 is that substance use is common. Point number 2 is that there are real consequences, even in the short term, not just down the road, but really in the very short term. Point number 3 is that we know how to identify substance use and substance use disorders. I'm showing you a shot of the screening to brief intervention tool, which was developed at Children's Hospital. It's a very, very simple tool. It just asks a couple of questions about past year substance use. The first question is about tobacco, and it's been updated so that now it's about tobacco and nicotine. We like kids to self-administer this and see those response items on the right about how often they use. You ask the same question about alcohol and about marijuana. And if all of those are no or never, the screening is done. If any substance use is endorsed, we go on to ask more questions about other substances. But this tool can be administered very, very quickly. It's very, very easy to use. It really takes less than a minute for kids to answer. And we know that it can help us pick up kids with substance use disorders. It's got sensitivity and specificity of over 90% for identifying alcohol use disorder and cannabis use disorder. So very quickly, we can identify if a kid is likely to have a problem. And not only that, but my brother-in-law is an economist, and he likes to say the difference between theory and practice is closer in theory than it is in practice. And so we know that that these screening tools work great in a research situation, but when we implement them in primary care, they don't always work as well. We've actually been doing quite a lot of work on that through the network affiliated with Boston Children's Hospital, and I'm showing you data from 3 different practices, as well as national data from the Monitoring the Future study, which is in yellow. And you can see that the rates of past year reported use are a little bit lower in two of our practices. In one practice, they're really nearly spot on. But we know that primary care is a slightly lower risk population than school populations because the kids who, because some of the kids who are the most frequent users don't show up necessarily for primary care. And so what I'm showing here is that we can actually get pretty good responses that are not that far off from school-based surveys. And this is actually pretty easy to do. All we've done in these practices is put the forms on paper and ask patients to complete them privately without anybody looking over their shoulder. We didn't actually do anything fancy these days because so much care is being delivered virtually. It would be reasonable to put this on a patient portal together with other screening tools that you might administer, but this is something really easy to do. And if we do it this way, it gives us pretty good results. So now I want to ask a question, and there's a little poll that should have just come up on everybody's screen asking, what do you think is the role of the primary care provider in reducing adolescent substance use? And you can see I've given you three choices. You're going to be forced to squeeze yourself into one of these boxes, but you can, well, my PCP's role is to do SBIRT, PCP role, there's more to the PCP role than just SBIRT, or I don't think PCPs really have a role in addressing adolescent substance use. So I'd like to give everybody a moment to vote on those, and then somebody will help us take a look at the results. And I'm just gonna let Beth and Sarah know that it's hard for me. I can't really see what proportion of folks have voted or what the results are. So if you can help me with that. There we go. Okay, so there's the poll. So I'm very pleased to see that nobody thinks that PCPs have no role in this. And it looks like about a third of you think that the role is SBIRT, and about 2/3 of you think that there's really more to be done than just SBIRT. Well, I just want to say that in my opinion, there is a lot more that we can do in primary care than just screening and brief intervention, which I think are really so important. But there are so many more things that are in the wheelhouse of the primary care pediatrician when it comes to dealing with substance use. So I see brief intervention. If you think of this as an iceberg, I think brief intervention is the tip of the iceberg. Certainly we ought to be screening and having these conversations with kids, but there's lots more that we can do. There are lots of medications that we can use to suppress cravings. And there are other medications typically that we use to address withdrawal when somebody's trying to quit using nicotine or quit using marijuana and they're having trouble because withdrawal symptoms keep them going back to drug use. For kids who are trying to quit, drug testing to monitor them can be very, very effective. And it's something that we can certainly do in primary care. It really doesn't take all of that much. We can also be doing education. We can be speaking to parents, helping them with behavioral contracting. All of these things, I would argue, can really be done in the primary care office. And certainly, we can be connecting these kids to behavioral health and then working together with our behavioral health colleagues to open a dialogue, make sure there's a back and forth conversation. So we each hand knows what the other one is doing. And this is not something that necessarily needs to take extensive periods of time. Prescribing a medication or providing education and following up patients as they go through, as they make quit attempts or cut down attempts. These are things that can really be done within the context of what we expect to do in primary care. I just am putting up there that there are lots of good medications that can help our patients quit using different substances. So for nicotine, of course, there's nicotine replacement. all of the evidence is really in adults, but the evidence is really pretty high, at least for cigarette smokers. There's a little less for people who vape, but we use the evidence we have from cigarettes to extrapolate. There's also proprion and varenicline that can both be used for older adolescents and young adults, and can be very, very helpful in the right patient, and certainly can go hand in hand with counseling to optimize treatment for kids who are trying to quit. And we also know that in national surveys, about half of kids who vape tell us that they've made a serious quit attempt in the past month. So lots of kids are really very interested in doing this, but on their own, they are more likely to struggle with that, and we can give them support that's going to make them more successful. Similarly, there's moderate evidence that N-acetylcysteine, which is sold as a dietary supplement, is actually very helpful in suppressing cravings in adolescents who are heavy marijuana users who are making quit attempts, and it can actually increase the number of urine samples that are negative for THC amongst kids in a randomized controlled trial, in a couple of randomized controlled trials, actually. And then, of course, there are medications for alcohol use disorders. I think we use these less in adolescents, but we certainly use them. And particularly when you're talking about, the older kids, kids in college who are really drinking very heavily and having trouble with control, with blackouts, with those kinds of problems. There's naltrexone and acamprosate, which can both be used for treatment and are both very effective. And then, of course, there are treatments for opioid use disorders. Buprenorphine requires special waiver training, but that can be accomplished in pediatric primary care. We have a couple of practices that have agreed to start prescribing and have done it with our support and have had overall a very good experience, I would say. And also we can use naltrexone, which doesn't require any special training, although folks who are doing this would probably want to get some support. And then, of course, we know that there are lots of therapeutic modalities that are also effective. I've listed them all here. There's actually pretty solid literature base showing that all of these therapeutic modalities are actually pretty effective. And really the key is getting kids to those modalities, getting them to counselors, and getting them engaged. Once we get them engaged, it almost doesn't matter which of these modalities we pick. Kids who get counseling on the whole tend to do very well with it. So lots of primary care pediatricians, there's lots folks can do. And we think just like lots of primary care pediatricians have questions about how best to treat mental health disorders among their patients, we think the same is true for substance use disorders. And so nearly a year ago, we created ASAP McPAP, which works just like McPAP for mental health problems. In fact, you call the same regional McPAP line, and if your question is about substance use, they'll put you through to the ASAP McPAP staff, and you'll get a specially trained addiction medicine staff member answering your call. And I'm just showing you the staff at Boston Children's Hospital. We've been fielding these calls for about a year, and over time the call volume has increased. This only goes through April of last year, but that line would continue to trend upwards over the past 6 months as well. And I thought I would show you just a quick sample of a couple of calls that have come in from into the ASAP McPAP line, the advice that was given, and also some written supports that we often hand out when we do these consults. So the first case is a pediatrician called to ask a question about a 17-year-old adolescent with a marijuana use disorder who's pre-contemplative but willing to do drug testing at mom's request. And so the PCP is asking, well, what should I do with this? And what's really the point of drug testing a kid who's telling me he's going to use marijuana? And that's really a very good question. But we actually think that drug testing can really be useful for self-monitoring. And when I'm working with patients and families, I describe it as using a scale for a patient who's trying to lose weight, right? So some of the kids that we treat in the subspecialty program are really fascinated to see their own levels of THC excretion in the urine, and how those levels go up and down with their use and the use of different products and the frequency of their use. And it really gets them focused on it. And sometimes just seeing those numbers, that kind of feedback is enough to get a kid really talking about it and thinking about whether they want to make a change. If they want to make a quit attempt, just to see what that looks like and feels like, it can be very helpful. If a patient does agree to make a quit attempt, what we would expect to see is at the corrected THC level, we correct for urine concentration, and it should fall by about half each week for the first couple of weeks until you get to minimal levels, and then it can stay there for a while, because a lot of people have heard that THC, because it's lipid soluble and can accumulate in fat tissue, will be around for weeks. That's true, but there's actually an exponential curve. We see it fall off usually in about 2 to 3 weeks. You're down to very, very minimal levels, and then it can just bump around a little. And since we know what no use should look like on a nomogram, we can really use that information. We can work with parents to set up rewards for decreasing THC levels. So we're rewarding good behavior rather than working on punishing bad behavior. And, we can follow up with kids just to look at those levels together and, discuss how they were doing and how it was going. And we have created a series. This is probably too small for folks to read, but we've actually created a series of written guidelines that people can use if you want to do any of these things in primary care. These are all single-page documents that just remind you exactly how to do it, including what orders to place, tips on collecting the specimen, and some suggestions on how to interpret the results. Here's a call that came in about medication management. So this is a 16-year-old male who presents to his pediatrician asking for help quitting vapes. We got a call to the ASAP McPap line, and we started him on a 14 milligram patch plus 4 milligrams NRT lozenge for whenever he had a breakthrough craving. 1 month later, he came back and he was doing really well, still wearing the patch most days, and the pediatrician called and asked for help in tapering. And so we helped transition the patch down from the 14 to the 7 milligram patch. And then we had them use the lozenges liberally. So if that jump was too big, he would replace it with oral nicotine, and then we would track how much oral nicotine he was using to make decisions about when to continue the taper. And we encouraged the pediatrician to stay in touch with us and see if he could help get this adolescent off of NRT. And just like with drug testing, we've created this one-page guidance. Again, it's probably too small for you to read, but it's everything you need to know about helping kids quit using either cigarettes or more commonly vaping, right? Including what the links are to support lines, how to start NRT, how to use other medications if NRT isn't enough.
Sharon, can I interrupt you for a moment?
Sure.
We have a couple of questions about drug testing in the question section. Andrea Sachs and another person just wanted a little bit more information about some of the mechanics of whether we ever have patients buy their own drug tests and bring them to our office, or if we exclusively do that ourselves, and if the former, or either way, if you could speak to the cost of drug testing as well.
Sure. So, there are a lot of options when you do drug testing. Parents can use home drug tests, but they're limited. First of all, they're more likely to give false negatives and false positives than the tests you can get at a commercial lab. And second of all, in the case that I presented here, which was a young man who was quitting marijuana after heavy usage, really going to need a quantitative level, which can't be done at home. So you're going to need, if that's what you're trying to do, you're going to need laboratory testing. Most insurance plans, in our experience, will cover laboratory testing we haven't had a big problem with that, although of course every patient's insurance package is different. So if there are any questions, I would direct a parent to call their insurance provider and ask about that. If you're going to use an official lab, we put some suggestions here right on the sheet of what you want to order, exactly how that's done to make sure that you're getting a quantitative level and that you're getting a specimen validity, which will also give us the ability to correct for urine concentration. So again, most of these are covered. If you're using labs, most of these are covered by insurance, depending on the patient's package. And if you're using the at-home tests, I think they can vary anywhere from $15 to about $50 for an at-home test.
Thank you so much. That's great.
Okay. And then, this was another consultation we received. This one was about behavioral health support. So just a reminder that we really take questions from anyone in the practice. So this was not from a PCP. This was from a behavioral health clinician calling about a 14-year-old male with 1-year history of vaping, THC, and nicotine. So somebody who started very young, mom had been setting limits, suspending privileges, but it didn't really help much. And the behavioral health counselor felt like he was at his, the bottom of his bag of tricks. So the advice we gave was really to talk to the patient about a quick trial. So even though they had been talking about this for a year, they actually hadn't formally asked the child to attempt a short-term quick trial just to kind of get things started and to see where they are. There had been a lot of demanding and threatening and all of that, but nobody had ever said, well, can we do this for 4 weeks just to see where things are? And actually the child was receptive. And then we designed a behavioral health contract together with mother and child, so that everything on there was something that mother felt was appropriate and kid felt was motivating. And we worked to restore privileges for each period of time that there was no use, and reset with each new use. So this mom had already been setting a lot of limits. Things were already pretty restricted. So we put in this behavioral contract a way to return the privileges, and that was actually pretty motivating for this young man. And then we referred. I'm sorry, was there a question?
You can finish your point. I was going to just bring up a couple more questions, but I didn't mean to interrupt.
Well, the last point is that we suggested that that the patient have a medical appointment to talk about symptoms of withdrawal and cravings, and to make sure that those were identified and treated, so that we could really help address those as well as possible as he tried to go through this quick trial.
So we have a couple of questions. One I think we'll save for later, but one that's relevant to what we're talking about now is the question about getting parents involved when teens don't want them to know. And so I wonder if you could speak to that sort of nuance of how you kind of negotiate this, with teenagers, and what point do you really sort of feel strongly that the parents, need to be involved in the process?
Okay, this is a question that comes up a lot, so thank you to whoever asked it. I think that if you've got an adolescent who's telling you about their substance use and doesn't want to bring their parent in the conversation, the first thing to do is to understand that better. And the first question is, is your parent aware that you use substances? It's really remarkable, but often the answer to that question is yes. I don't want to bring my mom in because this is my business and we fight about it all the time and it's just going to create an argument. So it's not really that the adolescent is trying to hide the information so much. The use is already out in the open, but it's just an issue of kind of managing. And so in that situation, this just really becomes a clinical exercise. And really, I would ask, in that situation, I would ask the adolescent, well, how would your mom feel if she knew that you were willing to talk to me and that, I'm really proud of you for having these conversations and I think we're making progress. Would she be happy about that? Would mom and dad be happy about that? Right? It's a way that we can use this really positively to say, hey, your child is really agreeing to work on this issue, and see if we can reframe that and then say, look, if you feel like mom and dad are overreacting, that might be something that one of our counselors can work with as well, or maybe I can give them some advice, or one of our counselors can work well, because the truth is, sometimes parents do overreact or they don't know the best way to handle it, and they can really benefit from advice as well. So that can be helpful to a parent. For kids who really feel that their parents don't know anything about their substance use, I think the question just becomes, what's the reason that they don't want to bring their parents, what's the reason that they want to get help without their parents knowing? So, in my experience, if a kid is willing to get treatment but doesn't want their parent to know anything about it, it's usually driven by one of two factors. Either the child is kind of embarrassed by their substance use and want to work on it and not really bring mom and dad into the picture. And I actually see that as kind of healthy. I'm certainly willing to respect that. And again, if it could be clinically helpful, if it would help a child get to appointments, or, if it would facilitate in some way, I would offer to bring the parents in. And again, trying to reframe this as something really positive. That, look, hey, you may have made a mistake by starting to use vapes. Your parents may be disappointed about that, but, won't they be pleased that you've figured out that actually this is a problem and that you're willing to work on it? And I think that's particularly an issue, for kids who you want to use medications for and things like that. It's very hard for adolescents to negotiate all of that without a parent involved. In some cases, in my experience, we've had kids who didn't want to tell their parents in a setting where there was domestic violence or child abuse and neglect. And I think in those cases, probably, want advice from child protection or, the DCF. But generally speaking, you certainly want to keep parents out of the loop if in the unusual circumstances in which that's the case. I think more commonly, we get kids who, who feel like their parents don't know anything about their substance use, and they don't want to tell their parents because they really don't want to work on their substance use at all. That's probably a more common scenario. And in those cases, I think what you want to do is really just keep it on the radar as, I'm your physician. I see this as impacting your health. And so I'm going to keep it on the radar, and I'm going to ask you about it again. I'd like to do a follow-up where I ask you about it again. I think that is a problem that, if you can't bring parents in, and certainly if you can't bring other members of a care team in, then it's something that, I think that we should expect as primary care physicians to manage, until the team can be broadened a little bit. And in those situations, I think that, typically one of two things will happen. If the use was very light, it may actually sort of peter out on its own, and then fine, you really don't have an issue anymore. But more commonly, the typical trajectory of substance use over the course of high school is that, kids who initiate will use more heavily, more types of substances, and more frequently. And so, I think you really want to want to keep an eye on it, because over time it's likely to be associated with more problems, more incidents, and at some point it's likely that parents will find out. I just want to show you that we do have a guidance for behavioral contracting as well. And these are all written for pediatricians to really help them work with adolescents and parents, but they can certainly also be used by other members, including the behavioral health team. So these are products that are all working with the MCPAP team and Department of Public Health to format them a little bit more nicely and make them available so they can be pulled online or available through, hopefully available through the clearinghouse in the near future. And with that in mind, so I hope I've given some examples of what I think primary care physicians can do that go a little bit beyond expert. There is one of the key pieces that that primary care providers can do is really hook kids in with treatment, recommend that they get it, and this is often something that's really very hard to do, because it's hard to find counselors who have the relevant expertise. It's certainly hard to get kids into those slots. Sometimes it's hard to get kids and families even motivated, to engage in this kind of therapy. And so we have developed this new ASAP MCPAP treatment program. The goal here is to lower the par. And now that so much treatment during the COVID pandemic is being given virtually, we're taking advantage of that opportunity to offer virtual substance use disorder treatment for primary care patients. So if you have a patient who you think could benefit from substance use disorder treatment, virtual care, and you don't have a place to send them, either within your own practice or a favorite go-to in the community, we can now offer that. And I want to just take a few minutes telling you how to take advantage of it. So if you would like to make a referral, first thing you do is you call your regular MCPAP number and ask for the ASAP MCPAP consultation line. You'll get one of the people on the, one of the clinician consultants on the ASAP MCPAP team will hear the whole story and discuss what a referral will look like. As we make that consultation, we're going to screen for safety and appropriateness of virtual care. So we'll ask you a couple of quick questions about that. I'll go over those in more detail in a second. Number two is we're just going to make sure that the family is aware of the referral. If you've already told a family, you know what, I've got a counseling service that I'd like you to use, I'm gonna call them and they'll get back to you, great. Then all we need is the contact information. If you have not yet discussed it with the family, we just need to make a plan to make the family aware. And actually this comes up, this comes up in ASAP, the clinical program, all the time, where folks will call and say, can you please offer my patient a referral? And the patient is actually unaware and surprised to get a phone call with us, which is always a little bit awkward. So we really want to make sure that families are aware and expecting our call. And then we want to make sure that we're getting the right contact information. If a parent is involved, we want to speak to the parent. If not, we want to make sure that we're getting the adolescent's contact information. So you want to make doubly sure that you're passing along the right phone number. This is how we will manage confidentiality. So if a family is generally involved and is aware of substance use and has been involved in a treatment plan, but not aware of the referral to ASAP MCPAP treatment, we will ask you or somebody in your office to actually have a conversation with the family. Once that's been done, ASAP MCPAP will call to collect any missing insurance information, whatever else we need, and schedule the appointment. If you're requesting that a patient get confidential counseling and the adolescent is aware of that, that's fine. We just want to be sure that we're collecting the adolescent's contact information, and then we will do a non-billed appointment if needed, so to avoid insurance information and explanation of benefits going back to parents. So once once we have confirmation and we've collected the appropriate contact information, we will complete the rest of the intake information and we will schedule the appointment. Often the consultant will be able to get enough information to confirm safety. If not, it's possible that the ASAP MCPAP treatment team will make another phone call, potentially to a parent, just to do a little bit of screening. And when I talk about the ASAP MCPAP treatment team, that will be Maria Alden, who's an LICSW, who's joined our team after working for a year in a private practice. And she will be under the mentorship of Shannon Mountain Ray, who is the Director of Integrated Care for the ASAP program. After our consultation, you will get a written summary with our impressions and treatment recommendations, what we're planning to do moving forward. Sometimes that will include suggestions that we think would be good to happen in primary care, including medications, potentially including drug testing recommendations, those kinds of things as options to do integrated care and to really bolster the care in collaboration between counseling and primary care provider. And then over time, as we work with the families, we'd like to keep the two-way lines of communication open. If we're learning some new information about the family, we'd like you that we think you ought to know, we'll give you a call. We'll also let you know where we are in terms of recommendations, and try and keep everybody on the same message. So when the child and the family come into your office, we can be sure that they're hearing the same things from everybody, from all sides, and not getting different information from different parties. And then this is just a final reminder that not every patient is a candidate for virtual visits. So there are a couple of things that make virtual care inadvisable. So severe depression with active suicidality, obviously that is somebody who needs more acute care and probably in-person care if at all possible. And so we would make other arrangements for a patient in that situation. If you have a patient with autism or communication disorder, often those patients have trouble in the online format. So that's probably not an ideal person to refer to us. And then if there's suspected child abuse or neglect or family history, that's probably also not a great patient to refer to virtual care. In fact, we would screen those patients out just because it's really hard to ensure that those patients can have private conversations when they're at home without having another professional in the room. So if we're hearing those things during the consultation, we will suggest something else. Including potentially an ASAP referral, so that we can actually have our clinicians meet with patients in person if we think that that is the next best step. Or we might refer them to a different program or a more urgent program if we think that that is advisable. I would actually like to stop here, and I think that leaves us plenty of time for questions. Before I do that, just want to acknowledge the entire ASAP MCPAP staff, including not only our consultants, but also our project managers and our admin leads, and of course, our treatment team. And so you can see that there are actually a lot of people behind this, or a lot of folks manning the phones and answering all the questions and creating these guidelines and getting this information out. So we invite you to use the service. We think at this point it's pretty robust, and we're hopeful that we can be helpful. Thank you.
Thank you very much, Dr. Levy. And we actually do have a few questions, and I think we'll have time for more as well. So I guess I'll take them in order, or I'll read them in order. The first is from Mark Friedman, who was asking if you could speak to the process of what happens when students get identified with positive drug screens. in school, because he points out that a lot of students get screened for substance use disorders in schools. And so what happens, when these kids screen positive, and what's the role for the pediatrician?
Yeah. That's so as far as I'm aware, I don't know of any public school districts screening using urine drug testing in Massachusetts, although in other parts of the country I know folks do. There might be some, I just am not aware of them. I do think some of the private schools use them. And so I guess if a child is coming to you because they've had a positive drug test in their and their school is requesting an evaluation before returning or something like that. I think that that is a place. The place really to start is with just a standard history and physical. See if you can get a substance use history to really understand what substances are being used and at what level and what problems, if any, are associated with that use, so we can sort of get a better understanding of where things are. That would certainly be somebody who, once you collect that information, if you could give a call to the consult line, I think we could take it from there and we could put together a program of recommendations, including, what do I do about the school? In general, we really hate to see kids excluded from school because they've had a positive drug test, although, we think that it needs to be addressed, but that might be a patient you could say to, clearly it's going to be very important to address this positive test. We could actually get you into counseling. We could actually say to your school, we think that you should go back into school and continue an evaluation and counseling services. ASAP McPAP treatment would be one way to do that, or another treatment referral.
Yeah, so thank you, Sharon, and actually Dr. Friedman clarified his question that he was referring more to the verbal questionnaires in 8th and 10th grade, and wondering, I suspect that there's no kind of fully realized kind of expert process for this kind of screening, and that it might be handled differently depending upon the school and the different staff who are involved. But I wonder if you could speak to anything that about sort of what the process is for that kind of screening in school.
Yeah, so there was a mandate a couple of years ago that all school districts introduce screening, brief intervention, referral to treatment, or expert 2 times in between middle school and high school, and so we've actually done a fair bit of research on that, and I don't have the answers yet. We're still analyzing the data, but we've collected surveys from more than 5,000 kids across 13 districts, and we are taking a look at that. What I can tell you, having interviewed the schools for this project, is that they are taking pains to ensure that there are no disciplinary actions for kids who are reporting substance use on this kind of screening. So they are, I think there are a variety of services offered by schools depending on the school and the district and what they have available to them. Probably the most common thing is following up and meeting with the school counselors. In terms of, we're just starting to get the first look at what this program is doing, and what we heard from schools and now what we're seeing in survey data. This is really early, but what it really looks like is that the program has been really excellent at introducing students to some of the counseling staff that are available to them in their schools, making those connections. And what we're hearing from students is that many of them feel like they have a place to go if they have questions or concerns about substance use, and that the relationships with adults are indeed protective for them. So it looks like there is a nice preventive effect, although we really, it's very early. We're still cleaning a lot of data and hopefully some reports will be coming out. But It does look like the preventive experience is going to be a good one, is going to be very solid. I have less to say at this point about the connections to treatment and how well those are coming off, and hopefully we'll be able to take a look at that too, but they're less common, and so it'll take us a little longer to tease some of that out.
Thank you. That's great. So the next question is from Andrea Sachs, going back to the drug testing, and she was wondering about whether you have any thoughts about nicotine drug testing, or if you really limit the drug testing to marijuana and other drugs.
No, it's certainly feasible to test for cotinine, which is nicotine metabolite. That's most typically what we would test for. Cotinine will stay in the system 2 to 3 days after nicotine use, so you get a window of use for frequent vapors. You'll see pretty high levels no matter when you test, and it'll give you a good sense. And again, for kids who are really trying to quit, I think actually getting their cotinine levels and showing them to them, that kind of feedback can be really helpful. We use it that way in ASAP, and I think it's very helpful. I will say, however, that if you are going to prescribe nicotine replacement, then you lose the ability to follow cotinine levels, because obviously they're going to be getting a pretty big dose of nicotine.
Thank you. That's great. So the last question I have so far is from Deborah Stahlbach, and I might speak to this as well, and so why don't you take the first stab at this? But her question is, I know the focus of this presentation is on working with adolescents in a pediatric primary care context, but she said that pediatricians, correctly, have a unique opportunity to identify substance use disorder concerns in the parents seen by the practice. And the question is, make PAP available to support providers who want help responding to concerns about parental substance use. Actually, since this is a McPap question, maybe I'll sort of take the first stab at this. As people know, McPap has a couple of spin-off sort of projects, or we have a couple of cousins, as they say, and so one is McPap for moms, and the other is McStap, which is actually really a substance use disorder kind of consultation program. Both the McPap for moms and the McStap program don't require enrollment, by specific, primary care providers, but they're really available as a service, for anyone. And so the McStap, the focus of that program has been, actually both of these programs are really focused on the needs of adults, and we all know that parents, and parental mental health and parental health issues are extremely pertinent to children's mental health. And so that's one of the reasons why we kind of include them under the McPap umbrella, but they do have different kinds of consultants. And so the answer is yes. We would love to have questions about how to address parental needs, whether it's psychiatric illness or whether it is substance use disorders, and we can do a warm transfer to one of these other programs, particularly if there are questions about referrals and care coordination and management questions. Not that the pediatrician is going to manage, the substance use disorder for the adult, but we certainly would, support the idea that pediatricians are going to help to kind of coordinate resources and really respond to these needs as they arise in pediatric primary care. And so that's my answer. What do you think, Sharon?
Yeah, thank you for that detailed answer. I think all of these points are extremely well taken, and one of the most important things that we can do to help kids is to help parents get what they need. So I agree with you. I don't think pediatricians are going to want to actually treat the parents. I mean, that requires a clinical relationship and a medical record and everything else. But I do think, and there's even been some research published showing that parents are really open to hearing from their kids' pediatricians. Some parents don't go to their own primary care, but take their kids to the pediatrician. I think pediatricians have a lot of credibility in this space. And so, identifying and making those referrals is really, such a wonderful thing that we can do. And thanks to MCPAP, there are places we can call that'll make that all very easy, rather than just saying to a parent, you really should talk to your doctor about this, right? It's something that may not happen, but actually being able to make the phone call, get the information, and help do the warm transfer.
That's really nice. Thank you. Thank you, Sharon. So we don't have any other questions. Why don't we just give people another minute or so if they want. Oh, looks like Deborah Stolbach just sent in another comment or question, and she actually requested that it might be helpful to send out a description of the different MCPAP programs, the attendees on this webinar. I know there's a lot of information on the website, but it could be helpful to have in one place. So that's a comment, and that's well taken. I think that we might want to do that. I think that's a great idea, not just for the participants in the webinar, but we might sort of develop a kind of a communication that would summarize, sort of the family of MCPAP type programs all in one place, just so that people can all be informed about those resources. So that's a great point. So again, so we don't have any other questions. I guess we'll say going once, going twice. We'll give people another minute if they want to quickly type something. But in the meantime, I just want to thank Dr. Levy again for such an informative and really well done presentation, and for all of her service, to pediatricians within MCPAP and outside of MCPAP through Children's Hospital, and also thank her colleagues Maria and Shannon, who were able to join us today. So it looks like there are no other questions, and so I think we'll adjourn our clinical conversations, and we'll look forward to seeing everyone next month. But thanks again, and hope everyone has a nice